welcome to the Alabama Public Health Training Network. My name is Shauna Lang, and I am the Director of the Home Care Division at the Alabama Department of Public Health. Welcome to our first internal patient-driven group model, commonly known as PDGM conference. Our presenters this morning are Sheila Duncan, our State Home Care Director, Michelle Paramore, Nurse Consultant, and Cassandra Miles, our Billing Division Director. Today we will review and prepare a prepared set of slides and answer questions received before this training. Then we will open up the phone lines and email lines for live Q&A. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts are available online. You will need to be registered for this program in order to access these materials. You can go ahead and email your questions anytime during the program or call when we open up the lines after the presentation. Now let's get started with the objectives for today. Our first objective is to define and explain PDGM, and then we will explain the potential effects of home health reimbursement. Then we plan to discuss home health clinical and billing relationship and the shift. We will discuss clinical and billing behavior changes. And then we will discuss ongoing training needs. The definition. The Center for Medicare and Medicaid Services has finalized the patient-driven group model, PDGM, which is planned to start in 2020. The agency has also finalized several other changes to home health providers for reimbursements which started in 2019. Tweaking remote patient monitoring rules and refining the value-based model. Among its provisions, PDGM is designed to remove current incentives to over-provide therapy services by more strongly weighting clinical characteristics and other patient information. According to CMS, PDGM would also mean that the traditional 60-day units of payment would be halved to 30 days. What we know, PDGM potentially be a reduction of 32% is expected. We must prepare a scripting for our intake team to ensure accurate information is received on the front end. Eligibility checks must be done every 28 days. We must learn how to adjust on the back end. Concerns currently are concerns related to whether the Palmetto is ready. Verifying adjustment accuracy must be done. Slow claim processing and our cash flow is expected to be reduced by 60%. Daily unbilled reports must be done. Goals for unbilling claims must be understood. Goals for past dues. Evaluating our order tracking process, and we must implement a centralized billing reporting of bills delayed. Analytical billing reviews must be done on a regular basis. Unbilled management is essential, and we will potentially have a double number of wraps and final claims. What we don't know. We will not know the full effects of PDGM until after several billing cycles occur in 2020.
So how this will affect home health. Each 30-day period of our home health admissions will be classified as institutional or community depending on where the patient comes from. Institutional would be a hospital stay, a skilled nursing facility, a long-term hospital, or an inpatient psychiatric facility. Community admission source would, of course, be no admission from the hospital. It would be straight from the physician's office or a family referral. The justification CMS has for this, they say that an institutional admission source is found to have a higher resource cost than those with community admissions. So in other words, we should expect more reimbursement from our institutional admissions than our community admissions. Under PDGM, our 30-day periods of care will be an early or a late period, just like we have now, except with PDGM, the first 30 days is your early episode, the second and later is your later episodes. And this information is going to come from our claims and not from our OASIS. Payment periods after the first initial 30 days are always considered community, unless there's an acute care hospitalization within the 14 days prior to your 30-day payment period. And a post-acute care stay is only a hospital admission. CMS is not going to see a skilled nursing facility, psychiatric facility as institutional for your second 30 days. So what they're saying is, if we have a patient that goes into the hospital during the two periods, the first two 30-day periods, and we do a ROC, when they come home, that second later episode would be institutional. It's from a hospital. But if they go to a post-acute facility, a skilled nursing facility, then it would be institutional. The admission source, again, will come from our claims processing, and we have the option of putting the occurrence code on the claims to identify our admission sources. How we update the claim requirements, we're going to add the Moon 90 date from the OASIS, so it's very important that we get our Moon 90 date correct, because CMS will see that as our admission day. So if we miss putting the occurrence code on our claim, they're going to come back and automatically adjust our claim based on that Moon 90 date. The occurrence code are our driving admission sources. We're going to change the diagnosis source. And home care, home base, we're going to have to set up the admission facilities. They're going to have a place for us to add the occurrence code 61 and 62 so we can show where the patients come from. Our later periods are always classified as community unless there's an acute hospitalization in the 14 days prior to the late home health admission. In order to capture the institutional stay, the patient would have to be discharged and readmitted. However, since we went to our meeting in Dallas, CMS has said you can do a ROC. You don't have to discharge your patient and readmit them to get that institutional admission. You can do the ROC. The diagnoses will no longer have to match on our OASIS RAP or final, and the diagnoses should reflect the patient condition at the beginning of the statement period. So each 30-day period, we should reflect the patient's primary diagnosis. Case mix groups cannot change within a period. If the primary diagnosis changes between the first and second 30-day period, the claim for the second 30-day period would reflect the new diagnoses. You would not change the claim for the first 30-day period. It is not necessary to complete a follow-up OASIS to change diagnoses in your second 30-day episode. The diagnosis codes change between one 30-day claim to the next, and there's no absolute requirement from CMS to do another follow-up episode, which we used to call the sick episode, because they don't have to match the claim. However, you would want to do the follow-up if the functional scores were going to change and we would get different reimbursement. But you don't have to do another follow-up just to change your diagnoses. Diagnoses for claims during the first period come from the plan of care, and diagnoses for claims during subsequent periods come from the most recent diagnosis order within the prior period. How this will affect our roles: our clinical staff will need to be more attentive to physical assessments, OASIS answers, physician orders, and timely order follow-up. Our clerical, billing, and clinical staff will need to strengthen internal communications to close clinical and billing gaps. The ADPH State Home Health Agency has one parent office. We have 25 branches, which means one error in one branch affects the entire state. We will need to conduct trainings like we're doing today to receive additional pending educational opportunities. We'll review all emails related to PDGM closely and share with staff, incorporate PDGM training into regular scheduled meetings, and we need to ask questions.
We will start off with an overview of both payment models. Currently, we are working under the PEPs model, which is the prospective pay model. It's based on a 60-day episode payment, and it is also focusing on diagnosis, OASIS, and projected therapy. We will have outlier payments. We have LUPAs that are 4 or less visits. We have PEPs that are partial episode payments, and therapy-driven payment models that are based on 153 case mix adjustment groups. Soon we will be transitioning to the PDGM model, which is based on a 30-day payment period for a 60-day episode of care. It focuses on admission source, timing, clinical grouping, functional level, and comorbidity adjustments. We will continue to have LUPAs, PEPs, and it focuses heavily on diagnosis and is based on 432 case mix adjustment groups. From the model of the PDGM revenue cycle, you will see that they are based on 2 30-day payment periods. The first payment period is considered the front-loaded visits, and the second payment period is considered the tapered visits. You will be billing 2 wraps and 2 finals for each 30-day period. For billing purposes, PDGM proposes to keep the wrap final claim billing methodology. CMS estimates the median time to submit a wrap is 12 days, so they are soliciting comments on if this makes sense. Statistics states that 5% of wraps are not submitted until after 60 days. New agencies, as of January 1, 2019, would not receive wrap payments under PDGM, but are required to submit a no-pay wrap. Because we are an existing agency, we will still continue to receive wraps, but soon they will phase out. Sources of admission are indicated by occurrence code on the final claim only, not the wrap. Medicare will automatically adjust these claims if community is indicated, but an institutional source submits Medicare claims. Clinical groupings and comorbidity adjustments are based on diagnosis on the claim and not the OASIS. We will be required to have at least up to 25 diagnosis codes on the claim as compared to only 6 on the OASIS. wraps. Wraps are required for each 30-day payment period. The goals for billing should be 3 to 5 days after the start of the period. Typically, wraps are paid within 7 to 10 days, and early wraps are paid at a 60-40 ratio of the total claim. This means that your first wrap, which is the first 30-day period, will be paid 60% in the front and 40% as the final claim. Any late wraps, which are any recurring 30-day periods, are paid at a 50-50 ratio of the total claim. The second wrap should be billed as soon as possible if you have OASIS and plan of care documentation. Wraps help assist with cash flow. What's required for our final claims? We need to successfully transmit OASIS to the repository. We need to have compliant face-to-face certifications, signed and dated orders, and signed and dated plan of care. Some strategies we need to focus on for PDGM. We need to tighten down workflow processes and set higher bars for outcomes. Face-to-face completion, corrections, signed and dated at 98% of the start of care. Our coding and OASIS review should be completed 95% on the second day. Orders should be completed and sent out and returned and signed and dated 95% within the first 30 days. And our OASIS should be completed and exported to the repository 98% within 7 days. Some other strategies we should focus on: possible shifts to our increased e-referrals. We need to ensure validation of demographics is completed. Audit should be done on claims adhering to the plan of care and supported by documentation. And dashboards should be used to note the percentage of clean claims submitted. We should make sure that all billing is done electronically as well as cash posting. We need to focus on what our pre-bill audits look like and collaborate with the clinical to improve outcomes if necessary. We need to have monthly reviews of our AR aged over 60 days, and we need to trend our denials by reason. More strategies we need to look for. We need to monitor admissions and recertifications and notify clinical if you cannot wrap within a specified time period. We need to monitor unsigned orders and face-to-face management. And we need to utilize an electronic physician signature portal. Some of our revenue cycle key performance indicators are case mix weight, OASIS error percentage, outstanding orders by age, days to final claim, our AR balance, days sale outstanding, write-offs, and rebills.
Your partial episode payments. Your PEP adjustments are made when a patient is transferred or discharged and then returns to the same or different agency, requiring new OASIS and plan of care within the same 60-day period. Payments are calculated as proportion of a 30-day patient under our care. So if they leave the first 30 days, we will get a PEP. And so we want to make sure that we avoid that at all costs. As we had said, there are LUPAs in our outliers. The LUPAs are proposed to reevaluate the LUPA threshold yearly based upon our current data. There's no change in the LUPA add-on payment. And the outliers is there's no change in our outlier calculation based upon our 30-day periods. The cash flow impact, timely variables, the wrap billing, and our OASIS completions in QA. Our wrap billing is going to be crucial for us with the timing since we have two 30-day wrap periods. Our PDGM wrap 2 in most cases will be the same as the OASIS. Our wrap 1 is going to be our leading and quicker billing timeline. So we need to get the strategies that has just been outlined to send in our wraps within the 3 to 5 days. The final claim billing. In order for us to do a final claim billing on our first 30 days, we need timely receipt of signed orders. We need timely completion of the face-to-face. And we also need timely receipts of visit and supply information. And that is in order to get our first billing out for us to be successful.
So the slide you're looking at now is how showing you a diagram of the HIPs and the HRG scores and how our HIPs will be calculated under PDGM. The first character of the HIPs code, which we've already discussed, is going to come from our admission source and the timing of the payment period, which of course will be institutional community, institutional early or late, or community early or late. The second character of the HIPs code will come from the principal diagnoses. It can be grouped into one of 12 clinical groupings, which describes the primary reason the patient's receiving home health. And of course, it again is based on our primary diagnosis. The third character of our HIPs code is going to come from your functional impairment score, which comes from certain OASIS questions. Those OASIS items that are going to give the functional impairment level are M1033, which is your risk for hospitalization, your 1800, which is grooming, 1810, which is ability to dress upper body, 1820, which is your ability to dress your lower body, 1830 will be bathing, 1840 is your toilet transfer, 1850 is your transfers, and then 1860 is ambulation. Those 8 OASIS items are going to give us the functional impairment level, and they'll stay the same during the first and second periods unless we have a patient go in the hospital and we do a ROC, or if we do another follow-up in between those periods and the functional scores change. The next character of the HIPs code is going to come from the comorbidity adjustments, which is going to be our secondary diagnoses. You could have none, low, which would be 1 secondary diagnosis, or high, which would be 2 or more secondary diagnoses based on their comorbidity list. The 5th character of the HIPS code is always going to be a 1 at this time. That character is just there for CMS to use at a later date. And then, of course, the HRG scores, that's going to come from the 432 different combinations between the OASIS and the claims data.
Presently, under PPS, we've always thought of LUPAs as 5 or fewer visits. With PDGM, that is totally changing. It can go down to 2 visits up to 6 visits. But the 2 visits depend on those HRG scores, and there are 94 HRG scores that you can use that has 2 visits for a LUPA threshold. But as you see, as there are like 137 HRG scores that can be for PDGM that has 4 visits. So we cannot just base our visit in the future in 2020 just and say that 5 visits or less will get a LUPA. It all depends on what we're getting for our HRG. Now, with these changes in PGM, we're going to have a change in our claim management, as we have talked through here, that the 30 days for Route 1 and 30 days for Route 2. CMS will calculate reimbursements based on prior claims in the common working file, diagnosis and visits submitted on the claim, and OASIS in the key system, not the HIPS code. We need to investigate all remaining balances that we have on our AR now before, with our new EMR, which is Home Care Home Base, before we start the new system on January 6, 2020. Also, it was referenced for occurrence code. As it been said, that is going to be very important about where we get our admissions from. Inpatient, hospital stay, or from the community. So we will have occurrence codes on the bill that will note this, and this will go to CMS and will note our payment. It's also important about your OASIS assessment date. That will be in your occurrence code 50. As it been noted, we must get those dates correct. And I know that we usually have put in the past a treatment authorization code on the bill. That will no longer be the deciding factor for us getting paid. Clinical and billing, PGM. The change requests, well, we've been processing all of these 30 days that came from CMS, was change request 11081. It changed everything from 60-day to 30-day episodes, 60 days date of care, but 30 days episode as in billing. We have a change with LUPAs, the no treatment authorization code. We've added those occurrence code 50, occurrence code 61, and 62. We have another change request that came from CMS that says OASIS and claim diagnosis does not necessarily have to match. I know previously with PGM we matched that information. It is not required at this time. Route payment is based upon HIPS code as submitted. If your HIPS code changed from one 30-day period to another, the Medicare system will adjust these after receipt of the final bill, and that's the final bill after the last 30-day period.
OASIS must be still completed every 60 days. The PEPs have the same methodology. Outliers have the same methodology, although fixed dollars lost would need to change. Based on the current rules, 4.77% of estimated total payments would be outlier dollars. CMS requires that numbers cannot exceed 2.5%. Non-routine supplies and add-on payments are eliminated. As you can see, there are a lot of changes that are pending for 2020. There are things that we know, but there are more things that we don't know, and we probably will not know specifics until several billing cycles have taken place in 2020. But what we know for sure, if we don't get it right, then we will not have, as the slide you're looking at says, we will not have any job openings, and we stand to lose a lot of money, and our pockets will be empty. So in order to avoid these things from occurring, we're trying to be prepared up front so that we can prepare you all so that we will be maintain our status in the home health industry and be open to take care of these patients in the state of Alabama. At this point, we're going to shift now and go to Q&A. Do we have any questions?
No emailed questions.
Okay. Okay, if you all don't have any questions that you can think of right now, we have prepared a few questions for your consideration based on some discussions from meetings that we've been able to attend. As we stated early on in the program, Sheila was able to attend the Home Health Summit earlier this year in Las Vegas, and Michelle and I went to the Home Care Home Base User Conference in Dallas, and both of those conferences we were able to sit through sessions that gave some specific information regarding PDGM. But again, a lot of the information is still questionable, but we needed to share what we know at this point. And as we continue to receive information, we intend to give you those updates. So we're going to look at some of the questions that we pulled down from the internet to just kind of go over some things. And while we're going through these questions, it may trigger your mind or some things that you would like to ask. So you still have time to write down your questions or call them in. And even at the conclusion of this program, if you have questions, please do not hesitate to call and ask your question, because it's going to be so important for us to get you the correct answer. One of the questions listed here states, what are the documentation aspects that you suspect may need the greatest focus in terms of training for the field staff? And the answer given states that, for starters, we must make sure that the clinicians do a good assessment. I'm going to repeat that. We must make sure that all of our clinicians do a good assessment. It is crucial that patients demonstrate their functional ability. You just can't consider what they say they can do. You have to see it. Willingness and ability are two different things. Really make sure the patient can walk 100 feet. For cases that have higher points like wounds, you are going to need to make sure you're documenting all of the secondary diagnoses. Ensure whatever documentation you have on the starter care assessments, you must make sure that the that your service pattern and the diagnosis code and comorbidity, all of these things are matching, etc. A coder can read, and you can read between the lines and assume things, because we are clinicians and we're nurses, and we see and we think that when we're reading things that we can fill in the gaps, but we can't make assumptions. If it is not written, it did not happen. It did not happen. You cannot get paid for it. The patients have certain issues or conditions, but if it is not documented, you will not get credit for it, as stated here. Start training your staff now, and that's what we're trying to do, so they can get used to the routine of making sure that when they're out making their assessments, they're doing as a complete job as possible. A second question here that's listed states, how important is it to do the EHR documentation on site with the patient versus paper notes and doing documentation in the home or the office? And the answer given states that documentation that can be captured at the point of care electronically is better. Capturing information electronically will enable you to share and collaborate more quickly with other team members, such as your coders, your case managers, and your clinical managers. Especially with the new 30-day payment model, completing documentation and getting orders out for signature is going to help facilitate getting faster and keeping your cash flow moving. I need to repeat that. Especially When now with PDGM approaching for 2020, 30-day payment model, we must complete our documentation, we must get our orders out to the physicians, and we must have them signed in order to keep our cash flow moving. We understand there are some limitations when it comes to retrieving MD order signatures back timely. We realize that some of these things are outside of our control, but we have to tell you that we're doing the best we can here at the bureau level to write letters, to contact physicians, trying to think outside of the box on how we can develop better relationships with our referring sources so that we can educate them on this transition from PPS to PDGM so that they can understand that the signatures of MD orders in OASIS is tied to our cash flow, which means tied to our business operation in order for us to be able to continue providing quality services to their patients. When Michelle and I were in Dallas at the Home Care Home Base user conference, a question was asked of the facilitators of that event and also those who were presenting. What is CMS doing to help us with this issue as far as getting MD orders back timely? And the answer was given that CMS is hearing the concerns because this is not a new problem, but CMS is not responding. So I know there are going to be some things we may not be able to do, but I want you all to try and do your best to develop those relationships so that you can get those signed orders back timely so that we can bill and won't have an interruption in our cash flow. I think we have a caller. Phone call is in from Coffee County. Go ahead, caller.
Yes, ma'am. I have two questions. The first one is, now that our LUPA threshold visits have changed anywhere from 2 to 6, will our nurses have something in the new EHR system to let them know when they're plotting out their visits that it may be a LUPA?
Michelle,
Yes, they will. So Home Care Home Base is going to have on the point care system, it's going to be color coded, so the first 30 days will be one color, and of course the second will be another. So that way the nurse knows which 30-day period they're in, so if they move a visit over, they'll know that they're going to be a LUPA. It'll give them a warning, and they'll also have the color coding. The thing about that is, and what we need to start working on, is our nurses are going to have the primary diagnosis up front. We can't really use the 000 or whatever we're using now. They really need the primary diagnosis for our services up front, so they'll be able to have that clinical grouping number so we'll know what visits are going to make them a LUPA or not.
Okay, that brings me to the second question. I believe I heard that we'll be required to have 25 diagnoses up front, but that's not a requirement. It just means we can have up to 25 diagnoses?
Correct. That's right.
Okay. Okay, thank you.
Okay. Any other callers? Any questions from the email?
No email questions.
Okay. Michelle, would you expound on question 3 that we retrieved from the email?
Yes. So this was about LUPA thresholds. If a LUPA threshold is listed as, say, a 2, is a LUPA avoided if 2 visits are completed or 3? The answer to that question was yes. In the example above, once you complete 2 visits, you've reached the LUPA threshold. It says, interestingly, with the PDGM, the LUPA breakout of the 432 HIPs is as follows. 2 LUPA thresholds, there's 94 HIPs codes. For 3, there's 128, and I think we saw this in our slide. For 4, there's 137 HIPs codes. 5 LUPA threshold, there's 63, and for 6, there could be 10 HIPs codes. Of course, currently in our PPS model, we have 153 HIPs codes. All have a LUPA threshold of 5. So as you can see, there are far more HIPs that have LUPA thresholds that are less than 5. Remember, the LUPA visit threshold count starts over for every 30-day period.
Okay. Okay, there's a fourth question. I think it's Cassandra is more built in line of billing. So would you expound on that for me, please?
Yes, ma'am. Okay, the question is there a published list of the reimbursement for each of the new HHRG groups. CMS has published a final case mix weight for each HIPS code. Of course, you have to consider which CBS code the patient is receiving the care in. CMS has also published an estimated grouper tool that will tell you how much an episode is worth based on the information that is entered, and you want to evaluate a patient on a case-by-case basis.
Okay. Cassandra, would you like to add an example of that?
Basically, they're going to focus on where the patient lives. They're going to use those groupings, as we talked about. It's 432 groupings that they have, and all of that will be based on how we do our breakdowns for the 2 30-day periods, and like they said, it'll be evaluated on each basis, by case by each patient.
Okay.
And that CBSA code is already in home care, home based, right?
Yes.
So when we put in the county, it already pulls the CBSA.
Pulls it. Yes.
Okay. Okay. Very good. Sheila, would you take question 5 and expound on it for us, please?
What implications, what immediate implication can come to mind when assessing the impact of PDGM on therapy-focused agency who operates on a pay-per-visit model? Agencies who perform a high number of therapy visits and are operating on a per-visit model are going to be agencies who have the most challenges. Now, as you know, we do have therapy in some of our particular units, and we have never been an agency who would provide a high number of therapy visits, but in the current PPS model, those therapy visits always generated more money than just regular visits. So the first challenge for them is to look how they're controlling their visits and their pattern. So we will be affected, yes, by the therapy due to the fact that we do have some therapy. But we will be looking at what exactly does that patient need and provide only that need. Well, the agencies who provided more therapy will have to look at are the therapists or the therapy companies controlling the visit pattern, or is the home health agency controlling the pattern? Because if the home health agency is controlling the pattern, it will be less, they will only provide the visits that are necessary, whereas the therapy company would like to provide more and more visits. So in the overall aspect for it, we as ADPH will continue our model that we have currently been working under, not providing excess visits, especially for those particular patients who have therapy, but we will provide what the patient needs as in regards to therapy. We hope to expand therapy all over the state. It's in just certain corners now, and where we have therapy companies and therapy contracts. But we will be providing just what the patient needs, and our home health agency will determine what that need is, not the therapy company. Also, I want to talk a little bit about the money impact. As y'all are aware of, I'm still the bottom line person with money. So when you're looking at money, starting with PGM, as it was told in the slide, we're going to be one of the people who are cash strapped as far as come January, February, and March. Because once the PGM starts, there's already been talk about we will have to submit ADRs. And with the ADR, you do not get any money until they make the final estimate of the final bill. That will be a lot of information that we will have to transmit to CMS so that they will see that. So we need to be really on point and probably talk with our administrators, which I will do that. But I will mention it to them, and I have already done that, to let them realize that January, February, and March of the new year is going to be really tight for home health and bringing in cash for Medicare. And remember, all we're talking about here is the Medicare patient. But our goal this year also have to be increase our Medicare patients, and there's a possibility with all this with PGM and with the therapy visits for other agencies that it's a possibility that we will get some Medicare visits in different parts of the state. Maybe not all, but we will get some. So I have let them know that, yes, we are going to be a little cash strapped at 32% less money than what we normally bring in from Medicare, but we are to continue to provide the service, provide what we need for the patient, and work with our PDGM model.
Thank you, Sheila. I think one of the things that was emphasized at the conference Michelle and I attended in Dallas is that with therapy, it's going to be so important for us not to, as Sheila was explaining, to overutilize, to front-load visits for the outcome for revenue, but and also to, when 2020 comes, that there's not a dramatic change, because if there's a dramatic change in utilization of therapists, that's a red flag for CMS. So we have to be very conscientious about that as well. And question number 6, the question states, so is there confirmation that therapy and nurse could do a joint start of care visit when the PGDM model occurs? And the answer states, there is nothing that will prevent an agency from sending a nurse and a therapist to a start of care visit together. Although it would be more expensive to send out both disciplines at the start of care, it would expedite any collaboration that would need to occur between the clinicians, the therapists, and the nurses, and get more accurate results, especially around functionality, impairments, and questions. But Michelle, I want you to expound on that as it relates to our policy and the way we function.
Okay. So currently, if nursing is ordered, our nurses do the start of care visit for the therapist, and the therapist will just do their evaluation after our nurses do their visit.
Okay. And then question 7 says, will there be a provider impact analysis for CMS like they have provided for PDPM? And Sheila, would you expound on that a little bit?
Yes, as they're looking at all the information that comes in, remember this is a new payment model. Well, CMS is starting this year. So always they're going to try to do an analysis to see exactly what the effect is having over all of the agencies nationwide. And once that analysis is come back, then they'll look at different things as to what was successful, what was not, what was changing. But I also need to remind you, too, that the CMS is a government agency, so they're looking for ways that right now, all this is to prevent fraud and things that what has been happening across the country. So the analysis could be good, could be bad, could be made for more changes that we will have in the future. But it will be an analysis done, and the analysis more likely won't come out until the end of the year due to the fact that PGM starts at the 1st.
Okay. All right. We have a caller from Tuscaloosa. Go ahead, caller.
Good morning, ladies. This is Jackie. I just wanted to thank you from the Bureau looking at what we can do to get these doctor's orders in. That seems to be such a huge problem.
Yes.
Even though most of our patients are Medicaid, it's still a major, major issue. And one of the things to consider, too, is we have a lot of patients that are from a doctor group. And the problem with getting the signed order may be with a doctor that is either no longer with the group, or there's some issue with them, or they're a resident, or they're an intern, or those kind of things. So anything that you can do to help us have a better way to deal with that kind of situation would be really, really helpful.
Okay. We appreciate your question, caller, and we have been in conversation with Dr. McIntyre, and she's been discussing with Dr. Harris some options that we need to take to address what you've asked Jackie, and also just the overall issues of being able to get our order signed timely, and what would be the backup for the situation you described when a physician is no longer in that group. But thank you for that question. Are there any questions that come in on the email?
No emailed questions.
Okay. All right. We do have one more prepared question that we pulled from the email. Michelle, would you expound on that, please?
So the question was about outsourcing ICD coding to certified coders. It says, is that something we need to do, or can we, the clinical manager, pull the primary and secondary diagnoses from the physician notes and admission paperwork? So coding is going to be more important than ever, of course, with PDGM, and it doesn't matter if it's an internal or outsourced coder. It's just very critical that we get the codes correct. The coders are going to understand whether the primary ICD-10 code comes from the physician fits one of the 12 clinical groupings. If it does not, someone will need to call back that referring physician and try to get a better diagnosis to fit into a clinical grouping. The question came about, though, is if the face-to-face as the primary is not listed in a clinical grouping, can we pull from the secondary diagnosis and change it to one that's in a clinical group? CMS says we can, the MACs say no, so there's confusion as to which way we're going to be able to go with that.
And Michelle, you mentioned the word, the acronyms MAC.
Yes.
Explain what MAC is, since you said it.
I said it, but I'm not sure I know how to explain it to them. It's our payments. Sheila, you can do that one.
Okay, go ahead, Sheila.
See, you know, it went out of my head. But when we talk about MAC, we're talking about the intermediary who is over the home health agencies that are in our region. Okay, and the home health intermediary who we send our bills to, who gets the information from CMS and funnel it down to us, is Palmetto GBA government. So we send all our bills to Palmetto. They send all their information to us. And even though the intermediary and the the CMS, who is the government in Washington, are supposed to be on the same page, reading the same regulation and agreeing to the same thing, sometimes they don't, because the intermediary decides that they want to do it this way and they require the agencies to do it this way, and CMS kind of let them go with it sometimes. But as in this situation, what Michelle is talking about, the CMS wants one way and Palmetto wants another way, and eventually, in order for us to get paid, we're going to have to go with whatever Palmetto comes up with, but we're hoping that it's going to be the same thing, because when we get audited by CMS. So if we're not correct with what CMS want, but we have what the MAC want, that's not going to do us any good, because we will get written up for that. And that's not going to help. So we're hoping that somewhere along the line they will release this confusion, but this is one of the things that we as the Bureau will keep abreast of and give y'all the latest information that we know.
Okay. Thank you, Sheila. And I wanted to spend just a little time in doing just what you did, ladies, because I know we've shared a lot of information with you all this morning, but there are still more unanswered questions than we have answers for. So we wanted you all to know that even when we send our emails or send our communications regarding what we're about to approach or happen in 2020, if we may come back and make some adjustments, and that's because the information may change. So please do not be frustrated by maybe what you would think conflicting information, but it will be simply the information that we have at hand currently, but it is subject to change. So are there any questions from email?
No.
Any more callers? Okay, if we don't have any more callers, any more questions, please know that, we understand the uncertainties around this big change. But if you have any question that come to mind at the conclusion of this program, again, as we stated earlier, please do not hesitate to reach out and contact us to get the answers you need to your question. This concludes our program for today. I want to thank Sheila and Michelle and Cassandra for joining me, and thank you for watching, and thank the audience that we have here in the studio. I know we covered a lot of information again, so please remember that you can refer back to the training and resources anytime on demand. Please have a great day. Bye-bye.